All right, hi everyone. I hope you're doing well. So in this lecture video, we are going to cover the slides on Chapter 5 on anxiety disorders. One thing that you will notice is that this will be a longer lecture video. It may end up being the longest one that we do this semester, and there are a couple of reasons for that. One, anxiety disorders have many different disorders within that umbrella category. So because of that, there are several disorders to talk about. But also because anxiety disorders are some of the most common disorders, there's been a lot of research and a lot of differing viewpoints on the proper way to treat anxiety disorders. So one of the great things about having these videos on YouTube is that you can always watch part of it, pause, take a brain break, and come back and watch the rest. So we will talk about the topic for Activity 5 in this lecture video. As always, make sure that your response is at least 200 words long, and make sure that your response is your own personal work. Let me know if you have any questions. Otherwise, let's start talking about anxiety disorders.
All right, so as I said, today's lecture is going to talk about disorders that we consider anxiety disorders, although we will talk about why obsessive-compulsive disorder could be included in anxiety disorders, but could also be put into a different category. So we'll get there in a little bit. Starting off with a general definition of what do I mean when I say anxiety. So most people know the feeling of anxiety. But actually, anxiety and fear are very similar to each other in how they are perceived. So it says both anxiety and fear have the same physiological features. So your body does very similar things. So if you're feeling anxious or if you're feeling afraid, your heart rate goes up, your blood pressure goes up, your muscles become more tense. It talks about perspiration here, so you may start to sweat, increase in respiration. In other words, you start breathing more quickly. So there's this fight or flight response that happens when we are both afraid or anxious. So then what is the difference between fear and anxiety? We use those terms pretty much interchangeably, but they're not exactly the same. Fear is a logical response to a threat to your well-being. So if you are in a genuinely dangerous situation, then having your heart rate increase, having your muscles become tense, having your breathing quicken makes sense. That's your body preparing to either run away or to fight off something that is a genuine threat to you. So fear is a response to an actual threat to your well-being, and the physiological response then is a healthy way for your body to help you handle a feared situation. On the other hand, anxiety, although it has a lot of the same symptoms, increased heart rate, blood pressure, respiration, or whatever, anxiety is a state of alarm that is not necessarily triggered by a particularly dangerous situation. So we're going to talk about several different ways that anxiety could pop up during today's lecture. But anxiety basically happens when you have a fear response when there really isn't anything that you actually need to be afraid of. Maybe there's nothing there at all, or if there is something there, your body's response is kind of out of proportion to the situation. You're responding more severely than you need to. So obviously, fear is an important response, and if a person did not have this fight or flight fear response, we would not be able to protect ourselves in dangerous situations. The difficulty is that sometimes it is hard to differentiate between situations that are actually dangerous and situations that just seem dangerous to us at the time. And so because of that, it can be a little bit tricky to actually figure out when a person has an anxiety disorder. Now, anxiety disorders are some of the most common mental disorders. So this set of slides has a lot of information in it. It's probably going to be the longest lecture video of the semester, and the reason for that is because so many people suffer, first of all. They're very, very common. We have a lot of research on these disorders, and because we're going to be talking about several different disorders as opposed to some lectures where we'll really just be focusing on one disorder. So in any given year, it estimates 18% of the adult population experiences one of these anxiety disorders that we're going to be talking about today. Now, a couple things to keep in mind here. This is probably a lower number because there are some people who, for whatever reason, are not aware that this is a disorder, or maybe perhaps are just not willing to talk about it because of the stigma, that kind of thing. Also, it says adult population, but some of these disorders we talk about today also happen in childhood. Many of them may begin in childhood and then kind of progress throughout the lifespan, but we are going to have a lecture later in the semester about disorders that are more common in children, so we'll talk more about the childhood version of anxiety disorders at that point. So about 29% of people will develop one of these disorders at some point in their lives, so this is very, very common. However, of those individuals who would meet criteria for a diagnosis of an anxiety disorder, only roughly 1/5 of them seek treatment. So this is going to be a theme throughout the class. You'll see that unfortunately these treatments are underutilized for many reasons. There is a stigma that's associated with them, with seeing a therapist, with having mental health issues. That's why I tell you guys at the beginning of the class, like, I have OCD, because I want to try to reduce that stigma in any way that I can. But there's a stigma associated also sometimes in rural areas. You may not know where to go to get treatment. You might not have access. Also, healthcare in general and mental health care, unfortunately, in particular, is very expensive. So that's an issue as well. It says most individuals with one anxiety disorder will also at some point suffer from a second anxiety disorder. So a person who has a tendency to be more anxious may fall into multiple categories and may receive multiple diagnoses. So that's called comorbidity, when a person is diagnosed with more than one disorder at a time. So the second disorder could be another anxiety disorder, but it could also be a different disorder. So for example, depression, which we'll talk about the overlap with depression in a second, and also maybe substance use, so maybe a person trying to self-medicate anxiety. Also, research suggests there's a relationship between ADHD and anxiety and mood disorders, especially in women. So comorbidity is definitely something to check on. If you have a client who has an anxiety disorder, you want to make sure you're not missing a second diagnosis as well. So today, we're going to be talking about generalized anxiety disorder. We're going to be talking about phobias and then a couple of diagnoses that would fit under that category of phobia. We'll talk about panic disorder and OCD today. However, we will not be talking about acute stress disorder or post-traumatic stress disorder today. We're going to separate those out into the next lecture video. We're going to have a lecture on disorders of stress and trauma. So starting off with generalized anxiety disorder, just like the name sounds, when a person has generalized anxiety disorder, this is the person that comes in saying, I worry about money, and I worry about the future, and I worry about my health and my spouse's health, I worry about my kids in school, and I worry that I worry too much. So this is a person who has several different areas of their life that cause them excessive anxiety. In addition to those kind of cognitive symptoms of thinking all the time about something bad that could happen, there may also be physical symptoms. So it talks here about sleep issues, muscle tension. So what you're going to see a little bit today, because I'm about to tell you, but you'll see this more when we talk about depression, is that the symptoms for generalized anxiety disorder overlap substantially with the symptoms of depression. Which means that if a person has generalized anxiety disorder, they also likely meet criteria for depression, and vice versa. Now, there's several different thoughts on that. Is that because we don't understand them well enough to differentiate? Is it because actually the root cause of one is the cause of the other as well? Are they actually the same disorder? We don't know for sure, but we do know is that comorbidity is high, so you'd want to check in on symptoms of depression if you have a client with generalized anxiety disorder. So restlessness, fatigue, difficulty concentrating, these are some of the symptoms you'll see. Now, these symptoms must last at least 6 months, and they must happen in addition to that listing all the different things that you're worried about. So you have to be anxious about several different areas of your life plus some of these other symptoms to get a diagnosis of generalized anxiety disorder. The reason it says at least 6 months is that most people will go through periods of their life where there's a lot of stress and they'll feel this way. Some of you may already be self-diagnosing. Some of this looks like a college student. The college student that's worrying about how to buy groceries and pay your tuition and make good grades in your class, and also you're not sleeping well and you feel tense. Okay, so some of you are already self-diagnosing here. Generalized anxiety disorder has to be a persistent problem over several different areas of your life for at least 6 months. Now, this disorder is common in Western society. Why? Well, we're going to talk in a second about some different potential causes for generalized anxiety disorder, but it's possible, and some people have theorized that because of the stress of living in an individualistic society, so our society tends to be more competitive, tends to be more isolated from social support than some other societies would be. Usually appears in childhood or adolescence. Now, the symptoms here may be difficult to diagnose at that age unless they're severe. Most kids have fears of something. They're afraid of the dark, or they're afraid of the boogeyman, they're afraid something's under their bed. How do you differentiate between that and generalized anxiety disorder? You may not be able to in the early stages. You may see this kind of escalating and getting worse as the individual gets older. But generalized anxiety disorder is something that can be diagnosed in childhood if it's, a pretty clear-cut case. Around a quarter, 25%, of those with generalized anxiety disorder are currently in treatment. So once again, this is very sad because we know that our treatments are helpful for not everyone, but for the majority of people who seek them out. But because of all those things we already talked about, sometimes it is challenging to get people into therapy. So where does generalized anxiety disorder come from? So this is what you're going to see as we go through lectures that talk about specific groups of diagnoses. We're going to go back and kind of think about our models of abnormality as we talk about potential causes and treatments. So a sociocultural perspective would say that there is something about our culture and our society that is potentially contributing to symptoms of generalized anxiety disorder. So, for example, what happens if you live in social conditions that are actually dangerous? So a couple of ways this could happen. One, you could have some natural disasters here. Living through a hurricane, perhaps. Maybe some of you have had experiences like this. You lived through some kind of natural disaster because you faced something that was genuinely a threat. So this is where it was fear. At the time it was fear. But that can then create kind of lasting anxiety afterwards. It could be a kind of natural disaster situation, or it could be, another example, what about poverty? So poverty is kind of a persistent stressor. Someone who is living in poverty has a long-term exposure to many different types of stress because of things like rundown communities, maybe communities that don't have access to resources, higher crime rates, educational issues with schools in that district, job opportunities are just not there. And then when you live in persistent stress combined with a lack of financial resources, that can greatly impact your health, because obviously stress is not good for your health. But when you combine that with a person maybe not having health insurance or not having the ability to pay for medical care, obviously that's going to be a health issue there. And based on this prediction, we would expect to find that generalized anxiety disorder would be more prevalent in lower socioeconomic status groups, or in groups that are more likely to be in poverty, and we do find that to be the case. Now, this is not necessarily causational, this is a correlation. There's a correlation between poverty and generalized anxiety disorder. Why is that a correlation and not causation? Well, I can't randomly assign someone into a poverty situation. So we just have to measure naturally occurring variables. But there does seem to be a pretty strong correlation there. Of course, that is not to say that generalized anxiety disorder is exclusive to people living in poverty. It's not, but it's found there more often than in other socioeconomic status groups. Okay, so then what about a humanistic perspective? So we talked about Carl Rogers, about his theory that a person is inherently good, but that something gets in the way and prevents you from being able to be the best you and to self-actualize, and that oftentimes the thing that gets in the way, you're lacking those conditions of growth that you need from other people. So, for example, Rogers said people need this unconditional positive regard. People need, in other words, you need to be loved and cared for regardless of your performance. You need people to be genuine and sincere with you, and you need people to be to have empathy, to be empathetic with you. So, according to that theory, then, imagine an individual that was raised in an environment where their parents or other relevant adults placed conditions of worth on them. I only love you if you make all A's. I'm only proud of you if you do exactly what I tell you to do. And as soon as you mess up, I stop being proud of you. Now, that individual would then live in a constant fear of losing the affection of their caregivers. So potentially because of that, that could cause some generalized anxiety disorder-like symptoms. So when you have those thoughts about yourself that you've internalized because you've heard them from other people, then that's going to harm your psychological health. Now the question is, how much stock can we place in this humanistic perspective? Well, basically, a lot of practitioners, as we said, use aspects of this client-centered approach, even if we don't use this exclusively. So the idea of trying to show your client that they deserve respect and care even if they're not perfect, that's a good thing to do. The idea to have genuine empathy for your client, that's a good thing to do. So we do incorporate aspects of this likely. As far as a standalone treatment though, it doesn't have a lot of strong support. There may be some case reports where there were some people who were particularly helped by this, but typically we use this in conjunction with something else. There's not a lot of evidence to suggest that it really is conditions of worth that cause generalized anxiety disorder, but you can see how having those kinds of relationships with caregivers could at the very least make these symptoms worse. Alright, so what about a cognitive perspective? Remember that the cognitive perspective says that it's not what happens to you that's the issue, it's the way you think about it. It's the way that you interpret your situation. So then, if you have a cognitive perspective on abnormality, then you would say a person who has generalized anxiety disorder, they're feeling anxious because they have some irrational assumptions about themselves and about life. So, just a few examples of what this could look like. There may be some people who have this assumption that it is a dire necessity for every adult human being to be loved by everyone. Okay, you probably either are this person or you know this person. There are people out there that cannot stand it when someone else doesn't like them. They cannot stand it when there's another person that is not their best friend. And so they go out of their way to try to make this person like them, which unfortunately can make the person like them even less. Now, it is really irrational here to assume that every person in your life has to adore you or else there's something wrong with you. But imagine that you were that person. Imagine that you were always constantly feeling like you had to be perfect because you needed to make everybody happy. There is no way to make everybody happy, but that would create a lot of anxiety. What if you have the belief that if things don't go the way you want them to, your life is over? Can you see how that could create generalized anxiety? A person who says, okay, well, that was my plan, that was the job I was going to have, that was the school I was going to go to, and so my life is over. I cannot function anymore. That person who has that assumption will probably have a significant amount of anxiety. So, according to the cognitive perspective, the problem is that you're responding to maybe typical natural events as if they are disasters. So, what you're going to do then is to try to, first of all, help your clients recognize when they have these maladaptive assumptions, and then, second of all, help them change those. So, this is sometimes called rational emotive therapy. Now, you'll notice that the rational term here, it's very logical. We're saying, okay, that belief that you have does not make sense. It is not held by the majority of people, and it's not working out for you. It's not helping you in your life. Instead, let's think about something else. Why don't we say, instead of saying every person in the world has to love me or I'm a failure, what if we say, I want my friends and family to enjoy being around me, and their opinions are the ones that matter most. So maybe there you still have some work to do. Maybe you have some friend and family relationships that you need to work on. But it's more realistic to say I'll fix a few relationships than to say I will have perfect relationships with everyone. Now, because you're only going to be with your therapist for maybe 50 minutes or so once a week in most cases, you're going to need to do some homework. I don't know if clients like the term homework. Probably if you've been in school, the term homework makes you shudder. So maybe you can think of another way to phrase that, but it's basically homework. Things that you do outside of therapy to help reinforce what you're learning in therapy. So maybe making notes throughout the week of when you have these assumptions and then replacing them with something that's a little bit more logical. Now, research suggests that this works at least a little bit. Well, think about this. If, as I said, generalized anxiety disorder overlaps significantly with depression, which it does, and if cognitive therapies were really designed to treat depression and are most effective at treating depression, it would also make sense that cognitive therapy would help with generalized anxiety disorder. And it does. But of course, there are other perspectives to consider as well. So we talked about a biological model where you believe that there's something genetic. Perhaps there's something with your neurotransmitters or something with your brain anatomy that's causing these symptoms. So biological theorists then would suggest that we are probably inheriting a genetic predisposition towards generalized anxiety disorder. Now there is at least some evidence to support this. If you have a close relative biologically that has generalized anxiety disorder, then about 15% of people will develop generalized anxiety disorder, whereas in the general population, it's about 6% of people. So you are at an increased risk for developing generalized anxiety disorder if you have a close biological relative with that disorder. Now, does this indicate the possibility of a genetic component? Absolutely. However, it may not be the genetic component. What makes this kind of research hard to do is that you often get your nature and your nurture from the same people. So, for example, if your parents have generalized anxiety disorder and you have generalized anxiety disorder, is that because they gave you some kind of messed up genetic code, or is that because you modeled your parents? You watched your parents experience the symptoms of generalized anxiety disorder. That was normal for you. That's what your childhood looked like. And so then you started doing what they were doing and modeling that. So the answer is it's probably some of both. But when we're looking for biological causes here, there does seem to be a GABA issue sometimes with people who have generalized anxiety disorder. Now, GABA is an inhibitory neurotransmitter. All that means is that it slows down the firing in your brain. So imagine with me here, if you're a person whose brain does not know how to calm down, wouldn't it make sense that you would have excessive anxiety? Sure. So remember our little discussion about biology, about how the electrical current passes the message down throughout the different parts of the neuron until it reaches the terminal junction. And then, because it doesn't actually touch the dendrites of the next neuron, the way that it passes that message is then chemical. Neurotransmitters are waiting, and they're released into that synapse, that little gap, and they cross and they bind with specialized receptors on the dendrites of the next neuron. So, GABA being a neurotransmitter that signals a slowing down of your firing, there are receptors there that receive GABA that can also receive benzodiazepines. So benzodiazepines, a particular class of drugs that reduces anxiety. So drugs that would be considered benzodiazepines, Valium and Xanax are only a couple, but they're a couple of the most commonly known ones, so that's why they're listed here. Now, there are differences in this class of drugs. Some of them work much more quickly. Some of them work much more, maybe they're more potent, so you have a more powerful effect. Some of them last a little bit longer than others, but basically all of them slow down that neuronal firing to kind of force your brain to slow down. Now, when we're talking about drugs to treat anxiety, and especially here, generalized anxiety, we started off with barbiturates. Now, I told you guys in a kind of historical lecture that the early production of these medications was really helpful because it allowed people who were in institutions to maybe function outside of institutions. Unfortunately, though, some of those early attempts at these medications had a lot of side effects, and so barbiturates were very powerful. I mean, we're talking about tranquilizers here. We're talking about the medications that they use today to put down dogs, okay? Barbiturates. That's what we were giving to people who had anxiety. Now, there may be certain situations today where people are given barbiturates, but it's much more tightly controlled for these days. We don't just give out barbiturates to everyone. Benzodiazepines are much more likely to be diagnosed today than barbiturates. However, benzodiazepines, while they are safer than barbiturates, are still potentially dangerous. So yes, they do work. The problem is that when you take a medication that reduces your anxiety, especially something like a benzodiazepine, which basically works by kind of knocking you out, when the drug wears off, the anxiety comes back. And so then you have to take the drug again. And so we're creating a cycle of addiction here. So it talks about physical dependence being possible. We will have a substance use lecture later in the semester. But also it can produce undesirable effects. So a person, depending on the dose and their own personal tolerance, it may make you go to sleep. It may make you pass out. It may make you kind of almost drunk, like when you take a benzodiazepine. So then imagine trying to drive or trying to go to your job when you've taken benzodiazepines. So it can be dangerous. Also, this will come up again in our substance use lecture, but let me say it now. Mixing drugs is very dangerous. So don't do drugs. Hear me say that you shouldn't do drugs. But also mixing different drugs together. So when you take two drugs that are of the same class, a similar function, and you take them at the same time, you get what they call a synergistic effect. More on that coming up later, but just don't do that. What happens when you take a drug like alcohol, which calms down your brain, and combine that with a benzodiazepine or a barbiturate that calms down your brain? At the very least, maybe you pass out, black out, but obviously overdose is a serious concern here. So be very, very careful with that. More recently, antidepressant medications here, SSRIs in particular, and antipsychotic medications. This may sound a little bit strange, but spoiler alert, antipsychotic medications are being given for a lot of off-label issues today. Alright, good. Generalized anxiety disorder can also be treated with other types of biological treatments that are not medications, so things like relaxation training. Generalized anxiety disorder involves a lot of physical symptoms, muscle tension, increased heart rate, increased respiration. So teaching a person to physically calm down, whether that be through deep breathing or progressive muscle relaxation or something like that, can then cause psychological calmness. So it's very hard to be having a panic attack and be calmed down physiologically at the same time. Now it says this may be best when used in combination with a cognitive therapy like we talked about, or biofeedback. Biofeedback would basically be hooking a person up to maybe a heart monitor or have something taking their blood pressure, and then they can actually see that their heart rate is declining a little bit, calming down a little bit while they're doing their relaxation training. Alright, moving on from generalized anxiety disorder, phobias. Now, fear is a normal and common experience that is healthy. As I said, a person who does not have a healthy amount of fear is a person who is likely to be involved in a lot of dangerous activities. When do you know that a fear is a phobia? A phobia is one of those terms that gets thrown around a lot, but how do you actually know when you have one? Well, think back to our abnormality lecture at the very beginning, the deviance and the distress and the dysfunction. So if you have a fear that is causing you emotional distress, or if you have a fear that is keeping you from functioning at your job, or if you have a fear that is just so out there compared to your culture and those social norms, then you might have a phobia. So this is intense, it's persistent, and usually the way a person responds is avoidance. So you do whatever you can to keep you away from the thing that scares you. Now, obviously, there are certain situations in which a phobia is more problematic than other. If you're a person who has a phobia of flying, like on an airplane, but you've never had to fly on an airplane, you don't work for a job that requires you to travel, all of your family lives close to you, that's not really causing you that much distress. That's not really going to cause dysfunction. But what happens if you have a phobia of flying on an airplane and you live in Hawaii? You're going to have to travel maybe somewhere. What happens if your job wants to send you on a lot of business trips? Then, in that case, it's going to start causing you some dysfunction. Now, most phobias are specific phobias, and you're going to see the criteria for specific phobias coming up. However, in addition to specific phobias, where you're afraid of a particular item, person, situation, we're also going to talk about social anxiety disorder and agoraphobia coming up. So, specific phobias: marked, persistent, and disproportionate fear of a particular object or situation, usually lasting at least 6 months. And then, of course, you're going to do anything you can to avoid being exposed to the thing it is that you're afraid of. Now, some of the things that are most common, specific animals or insects. So you may have a phobia of dogs, or you may have a phobia of spiders or snakes. Heights, enclosed spaces, weather-related phobias. It lists blood here, but needles could also be an example. Let me give you an example here. I know an individual who had a root canal without any kind of numbing because he was afraid of the needles that would numb his gums. Now, I can't even imagine having a root canal without some numbing, okay? But you can see how a person who has extreme fear could then have some major health repercussions of that, because you're afraid. Like, if you're afraid of needles, then you're probably not going to go to doctors. If you're pregnant, you may not get prenatal care, that kind of thing. All right, so every year, close to 9% of all people in this country have symptoms of a specific phobia. They may not be diagnosed, may not be recognized, certainly may not be treated. It says that women outnumber men at least 2 to 1. This is true of pretty much all of the internalizing disorders, which would be things like anxiety disorders and mood disorders. They tend to be more common in women. When we're talking about specific phobias, women outnumber men at least 2 to 1. Now, is that because women actually have more phobias than men? Maybe. Or it could be because women are more likely to be diagnosed. The vast majority of people with specific phobia do not seek treatment. Maybe it's because they've heard about the kinds of treatments we use. So we're going to get there in a second. Where do phobias come from? There are many different potential explanations of where phobias come from, but many of them are behavioral in nature. So we talked about behaviorism as the idea that what we do is learned through modeling or through operant conditioning, which was the rewards and punishments, or through classical conditioning. Classical conditioning is one of the most common viewpoints of where phobias come from. So follow with me here. Imagine that you were in a car accident and you were trapped inside of your car. So being trapped is an unconditioned stimulus that would cause an unconditioned response of fear. In other words, if you're trapped in a car, it's natural for that to cause anxiety. But what happens if there's running water? What happens if you can hear running water, or maybe there's some water filling up the car? Obviously, you're going to pretty quickly learn the association. The running water sound was originally neutral, maybe even relaxing. People like the running water sound. You can have your sound machines put you to sleep with sounds of running water, right? Well, it's originally neutral. But what happens if that becomes paired with being trapped? You're trapped and you can hear the water running. Now, because you're trapped, you're feeling anxious, and there's water running as well. You learn the association between the running water and the entrapment, and running water, which was originally neutral, becomes a conditioned stimulus now capable of causing fear. Basically, all I'm saying is, if you're in a scary situation and there's a background noise that's paired with that scary situation, you may learn internally, that noise is a sign of danger, and so you become afraid whenever you hear that noise, even if there's not a dangerous situation. Let me give you another example of this. Imagine that you had a family member who was going through a serious health situation, maybe cancer treatments. Having a family member go through severe pain and physical issues can cause a lot of negative emotions, fear and anxiety, right? So having a family member going through cancer treatment is an unconditioned stimulus that causes unconditioned response of some really negative emotions. Now imagine that you learned the association between your family member having cancer and vomiting, because people who have cancer often receive things like chemotherapy that can cause vomiting. What can happen is that you learn this association, and over time you can develop a phobia of vomiting. I've seen this happen. And so something that was originally neutral, or at least vomiting, while not pleasant, nobody enjoys that, wasn't that serious. But now, because you've learned that association, now even the thought of vomiting creates a really negative emotional reaction in you. So this is the idea about where the phobia itself develops. Now, where else could it develop? Well, it could develop through modeling. What happens if you live with a person who has a phobia and you're constantly seeing that person being afraid? You might start to be afraid too. Best example I can think of this, I am completely ashamed. My daughter mimics my responses to insects. Okay, I'm not a huge insect fan. I wouldn't say I have a phobia, but if I get surprised by a roach, I'm going to scream and freak out. Okay, so now my daughter screams and freaks out whenever she sees a roach. Part of that is probably just her dramatic flair, but also she's modeling what she's seen through me. Phobias are maintained through avoidance. So if you're afraid of something and then you avoid it, you feel better. And that relief that you feel is reinforcing. So that next time you come in contact with the feared thing, you're going to avoid it again. So imagine a person afraid of elevators. They're really, really anxious, so they decide to take the stairs. Taking the stairs reduces the anxiety they were feeling. And so that's reinforcing. And so now, if they're given an option between riding the elevator they're afraid of or taking the stairs, they're going to always take the stairs. The problem is that if you never face your fear, then you'll never know that you can face your fear. So that's a problem. Also, a person who has one phobia may develop other phobias and can potentially even end up with generalized anxiety disorder if there are enough separate situations that create anxiety. So, what causes specific phobias? Well, one thing that's interesting is that there are certain things that are much more likely to be the object of a phobia than others. Things like snakes and spiders. So, why does it make sense for us to be afraid of snakes and spiders? There's a theory that this is a biological preparedness issue. That as a human, it makes sense for us to be afraid of things that can kill us. Now, think about me here. You think, okay, well, what about people who are afraid of the dark? Well, the dark can kill you. I mean, I'm sorry. I'm just being very blunt with this. But there could be something in the dark that's dangerous and you don't see it. So the things that you're afraid of might actually be something that has its root in reality. It does not make sense for a person to play with venomous snakes or to play with venomous spiders, right? So perhaps we are predisposed or prepared to develop certain phobias because they are good for our health, because they save our lives to a certain extent. Now, there is nothing dangerous about looking at a picture of a snake. So if it's gotten to the point where you can't even go to a museum or a zoo because there's a picture or there's an actual animal there, that's extreme. But it would make sense for us to be afraid of certain things that could potentially be dangerous to us. Now, of course, there are some people who have phobias that are not particularly dangerous to us. So then we have to start wondering, if this biological preparedness is true, why is it that some people have phobias of balloons or other things like that? This doesn't explain every single case, but it could explain some cases. All right, how are we going to treat specific phobias? We actually have several different options. And when it comes to phobias, there actually are best success rates. So if you have a really motivated client, you can cure. I'm going to use the word cure. You can cure a phobia. Unfortunately, they have to be a really motivated client because some of these treatments are not a lot of fun. So let's start with systematic desensitization, which is the kinder, gentler treatment for a specific phobia. I think we touched on this a little bit in an earlier lecture as an example of classical conditioning. So this is the idea that when you're afraid of the object, whatever it is you're afraid of, you have all of these physiological responses, right? Your heart's racing, you're sweating, you're hyperventilating, okay? So what happens is we need to teach you relaxation skills first of all. So we teach people how to do deep breathing. We teach people how to do progressive muscle relaxation. Once we do that, we create a list of all the things that scare you and put them in order. And then we'll start with some of those that are very minor. So maybe looking at a picture of a snake. Maybe that creates a little anxiety in you. While you look at the picture of the snake, we're going to practice our relaxation techniques. We're going to assume that if I can force your body to calm down, your mind will calm down as well. And then once you have some success with those easier things, then maybe we move up to watching a video of a snake. And then once we have maybe some success there, we move on to being in a room with a snake that's in a cage. All the way up to the very top, which would probably be holding a snake, right? Now, if we teach you to calm down over time, you will probably start to learn to be a little more relaxed around the thing that scares you. Now, this is an effective technique that people tend to like because it's gentle. You kind of gradually work your way up to the scary thing. However, it does take a lot of time, so this is not for the client who needs to be cured quickly. Now, any kind of exposure, which this is exposure therapy, it's just a kind, gentle exposure therapy, but any kind of exposure therapy will either be what we call in vivo or covert or imaginal. Now, in vivo is actually physically handling the snake, for example. You hold the snake yourself. Covert might be imagining that you were holding a snake. Now, why is it that you would ever use imaginal when you could use in vivo? In vivo works better. Having the person physically in the situation helps them overcome their fear more. But there are some times when you can't. So imagine that a person has a phobia of hurricanes. Well, you can't conjure up a hurricane, and even if you could, it'd be dangerous for you to take your client and throw them into a hurricane. Obviously, you're going to get sued for that. So maybe we can do something imaginal with that. If you have that client who has a phobia of vomiting, the in vivo exposure is going to be pretty unpleasant. Although I have heard of people doing that. I've heard of like faculty members paying their grad students to take Ipecac and throw up in front of clients. It makes me always wonder how much you have to pay someone to throw up for your client. But anyway, that's a whole nother question. However, if you don't want to deal with all the vomit, then you could do imaginal. But in order for imaginal to work, you've got to really do this in a lot of detail. I worked with a client, and we did imaginal treatment for phobia of vomiting. It was unpleasant for me to talk about, to sit there and describe the texture and the smell. Right, you're getting uncomfortable probably just listening to this, but for imaginal to work, you have to really make sure they're imagining it. You have to really make sure that they're in the moment there. All right, moving on. Other things we can do, flooding is extreme exposure, not gradual, forced exposure. Of course, you're going to want to get your clients complete permission to do this. Your client is going to be very uncomfortable for the first part of this, but it's incredibly effective. If you want your client cured in an afternoon of a phobia, flooding is the way to go. So this is where we don't worry about the learning to breathe deeply, and we don't worry about the starting with the picture. We put the spider on your hand from the very beginning. We put the snake in your hand. We have the person throw up right there in front of you. Why? It sounds cruel, but follow with me here. When you have that panic reaction, your body freaking out, your body can only maintain that for about 20 minutes or so, and then it's going to have to calm down. Your body just can't. You'll get exhausted. You'll run out of adrenaline, and your body will calm down. Also, if you put a spider on my hand and I'm panicking, but nothing bad happens. Now, you need to choose your spider very carefully here, obviously. But if you put a spider on my hand and the spider doesn't bite me and nothing dangerous happens, eventually you'll calm down. This is very effective, but the client has to be really motivated to do this. So you might start with modeling. Modeling is when the therapist does it in front of the client. Now, you want to be cautious here, because what happens if the therapist is also afraid of the feared object? What happens if you have a phobia of spiders and you're trying to hold the spider for your client? You could end up reinforcing that. But as an example, I had a supervisor tell me that he had a client who was afraid of roaches, and this was disturbing for the client. So they went out and got some Madagascar hissing cockroaches, and the clinician held them for a while and then let the client hold them for a while, and by the end of the day, you had a Now, one thing to note is, all I want you to do is to have realistic responses here. You don't have to love spiders. You don't have to love cockroaches. The last thing I want to do is make you love vomiting. I want you to have a normal reaction to the feared object. Now, all of these work as long as the client is motivated. So actual contact seems to be the thing that is most helpful, which is why in vivo flooding is the gold star. But what happens when you can't actually put the person in the feared situation? Virtual reality. That's perhaps an option. If you have a client that's afraid of flying, you may not be able to afford to have your client go around the world on an airplane all day, but you could have potentially virtual reality that could also work pretty well. All right. What about agoraphobia? This is not a specific phobia. This is a more generalized phobia. Agoraphobia happens when a person is basically afraid of public places or situations, especially those situations where they fear that escape may be impossible for them. Now, previously, we only thought of agoraphobia as happening in the context of panic disorder, which we're going to talk about panic disorder in a second. We used to have the diagnosis panic disorder with agoraphobia or panic disorder without agoraphobia. We recognize now that although they do overlap a good bit, it may be possible for a person to have agoraphobia without necessarily meeting criteria for a panic disorder. But you see the list of criteria here. Fear of things like public transportation, parking lots, bridges, theaters, confined spaces like that. Basically where they feel like they can't escape or they can't get help if there were some kind of problem that were to arise, and so the person starts to avoid those places. And after a while, the person may only feel safe in a limited number of places. The stereotypical agoraphobia case would be a person who would be afraid to leave his or her home, right? Now, these symptoms usually continue for at least 6 months before we're going to be making a diagnosis, so it's not something that's a short-term, but kind of a long-term problem. Now, where does agoraphobia come from? Well, we're thinking that part of this may just be similar to the phobia issue, so maybe classical conditioning, maybe modeling, for example. But also there's this association with panic disorder, which we're going to touch on in a second, but this is a person maybe who's had a history of panic attacks. Imagine if you had a panic attack in Walmart. Maybe then you say, okay, well, I don't ever want to go to Walmart again because maybe I'll have another panic attack. But then you have a panic attack at your favorite restaurant. And then you say, well, now I can't go to Walmart and I can't go to my favorite restaurant. After a while, you have panic attacks in several different places. You may start to feel like you're only safe at home. So although it doesn't have to happen that way, that may be the way that it happens most often. Now, another example of a phobia that's not as specific would be social anxiety disorder. Now, social anxiety disorder can happen in specific social situations, or it could be any social situation. So, for example, a lot of people are afraid of performing in front of others, or maybe afraid of speaking. So, oftentimes, the class that students avoid like the plague is public speaking, like speech. So, I think a lot of people have at least a certain amount of anxiety, but we're talking about people who have extreme anxiety for social situations. It's kind of awkward eating in front of strangers sometimes, but these are people who go out of their way to avoid a situation where they might have to eat in front of another person. Or it could just be generally afraid of, maybe making a fool of yourself in front of other people to the point that you avoid people altogether. So, in these situations, what we typically see is that people have very negative viewpoints of themselves. Now, hopefully by this point we're making connections. And having a negative viewpoint of yourself would be a cognitive perspective of where social anxiety disorder comes from. So, one of the best known or one of the most researched explanations here would be a cognitive viewpoint of social anxiety disorder. Basically, imagine your life if you had really unrealistic social standards. I must never say anything embarrassing whatsoever. What if you viewed yourself as being unattractive? What if you thought that you didn't have social skills? What if you thought that you were constantly behaving in ways that are inappropriate? And then because of that, terrible consequences will happen. No one will want to be friends with me. I'm going to lose my job. Imagine you felt this way. Now imagine how that would impact your daily life. I'm kind of hinting at the activity coming up later. But imagine what your life would be like if you had this kind of anxiety. So then, if our viewpoint is that your social anxiety comes because you have these maladaptive assumptions about social interactions, then how will we approach treatment? We'll try to help you have more realistic viewpoints of ways to interact with other people. So, we have been able to form some pretty effective treatments for social anxiety disorder that usually combine that cognitive aspect of helping people change the way they think about themselves and others, combining that with a behavioral aspect of exposure therapy. If you have a person that is afraid of spiders, and the answer is for them to hold a spider, even if it's unpleasant, then a person who's afraid of social situations must go have social interactions to help them overcome that. However, caveat, before you throw the person into a social situation, let's help them be prepared for it. Maybe the person genuinely is a little bit lacking in the social skills department. So maybe we can help. Maybe we can practice interacting and help them develop better social skills. Maybe we can give them some assertiveness training. So teaching them to assert themselves in an appropriate way, not in an excessive demanding way, but in an appropriate way. So then they are more likely to be successful when you do force them to have social interactions. Alright, so we talked about agoraphobia, and so related to agoraphobia is going to be panic disorder. Now, panic disorder is going to include a pattern of panic attacks. Now, several things to say here. First of all, panic is a normal reaction if you're in a dangerous situation, just like fear we talked about earlier. Panic attacks are different because they don't happen in a dangerous situation. If you are being assaulted, if you are being attacked by an animal, it is normal for you to panic in that situation, and that wouldn't really be considered a panic attack. Panic attacks kind of come out of the blue and not really in situations where they would be expected. The other thing to say is that just because a person has had a panic attack does not mean they have panic disorder. You have to have a pattern of panic attacks before you meet criteria for panic disorder. Now, the tricky thing is that these attacks often feel physiological. So oftentimes it's kind of mimicking heart issues. People will go to the emergency room thinking they're having a heart attack. So I'm dizzy, I'm sweating, I can't breathe, I have this pain in my chest, and so they're afraid they're going to die. They're afraid maybe they're afraid that they're losing their mind. And so they might go to the emergency room. Now, it's going to be tricky to work with these clients and convince them that it's not a physical problem. You need to have, and you need to give them medical testing to make sure it's not a medical problem before you tell them it's not. But it often feels like a medical problem. Now, as I said, it does not necessarily mean that you have panic disorder if you've had a panic attack. About 25% of people have at least one panic attack at some point during their lives. And I would say probably the number may be even higher than that. When we're talking about panic disorder, you're having a persistent pattern of panic attacks combined with dysfunction. So if you have panic disorder, you start avoiding those places where you have panic attacks. That's how agoraphobia comes into the picture. You start planning your future around, okay, if I have a panic attack, where are the exits? How can I get away from this situation? You start avoiding maybe even talking to other people because you don't want them to see you have a panic attack. And so panic disorder is not just the presence of a panic attack, it's when panic attacks take over your life. Now, as I said, panic disorder often, but not always, goes along with agoraphobia. People who have a history of panic attacks may want to feel like they're in a controlled environment to try to reduce either A, reduce the panic attacks from happening, or at the very least to have their panic attacks in private, not in front of people. Now, there's still a lot more research to be done here. As I said, we haven't always understood agoraphobia well. We've only recently been able to recognize that agoraphobia can happen outside of panic disorder, so there's still a lot of research to be done in this area. Alright, what causes panic attacks? Well, panic attacks feel incredibly biological, and so let's start off with a biological viewpoint here. Perhaps there's a neurotransmitter issue. Norepinephrine is an example of a neurotransmitter that seems to be associated with panic disorder. So then, if there's a problem with norepinephrine, then perhaps a medication that aims to work on norepinephrine could help with panic disorder. It's also possible, though, that there may be more systemic issues in like the circuitry or the amygdala. Now, the amygdala is kind of the fear and anxiety portion of your brain. And so if you have some kind of issue with your amygdala, then that could potentially be contributing to these symptoms. But remember our diathesis stress model about how you can have a genetic predisposition, and then whether you actually have those symptoms or not depends on whether or not you're put in those stressful situations. So is it potentially genetic? Yes, it is possible that if you have a family member who has panic disorder, you're more likely to also have panic disorder. But of course, there's always that question, is it genetic, or are you maybe mimicking the things you saw in another person? Now, if we're thinking about medications that are going to help treat panic disorder, obviously anything that helps with norepinephrine will likely help, at least to a certain extent, with panic disorder. The problem is that when you give a medication to treat a specific disorder, what happens when you stop taking that medication? Oftentimes, but not always, oftentimes the symptoms come back. Now, when would you ever stop taking the medication? Well, what happens if a client becomes pregnant? Or what happens if a client has side effects from that medication, or if a client needs to take a different medication that doesn't play well with the medication they're already taking? There is always the possibility that a person might have to stop taking their medication. So, although, yes, drug therapy is very helpful, we want to also have other options as well. So, based on that, then, we need a therapy option here. So in addition to a biological viewpoint, we could also have a cognitive viewpoint. The cognitive viewpoint is always that we are interpreting our situation in a way that's not ideal. So a person who's having panic attacks, if they talk to a psychologist who has a cognitive perspective, the cognitive perspective therapist would say, well, you know what? Everybody has their heart race sometimes. Everybody breaks out in a cold sweat for no apparent reason sometimes. The cognitive therapist would say, it's not what's happening with your body. It's that when that happens, you panic. You realize, oh wow, my heart's going really fast. I must be having a heart attack. And the thought processes make the physical symptoms worse because you misinterpret them. You think that there's something wrong when there's really not. So the cognitive treatment is to help educate people, to help them know what is normal and what is not normal in their bodies, so they'll know whether there's any reason to panic or not. So, we're going to try to correct people's misinterpretations of their bodily sensations. So, first of all, I'm going to educate you. What does panic feel like? What is the overlap between panic and, physical issues? Also, what's normal with your body? Sometimes people are not aware that, you'll have your blood pressure spike every once in a while. That's okay. So helping people understand what's okay and what's not okay as far as physiological symptoms go. And then teach them to think while they're under stress, teach them to think about their body in a more realistic way. Okay, my blood pressure's high, so what I need to do is to breathe deeply. What I need to do is maybe separate myself from the situation I'm in, maybe go do some progressive muscle relaxation. Instead of thinking, I'm dying, I'm having a heart attack. And then we're going to put them in the actual situation and let them practice. So if you're learning coping skills, if you're learning how to calm down, if you do that in the office with the clinician, that's fantastic. But what I really want you to do is I want you to be able to do it at your job and at home and at Walmart and wherever else you need to practice this. And that leads to the biological challenge, or what it's also called Enteroreceptive Exposure. All that means is you take a person who has panic attacks and you expose them to physical sensations that feel like a panic attack. Now that sounds cruel, right? Exposure therapy often sounds cruel. And to a certain extent it could be if you were doing it in a mean-spirited way, but we're doing it to try to help people get better. Leaving a person with untreated panic disorder is also cruel. So we take a person, we induce those physical sensations. We can do that through exercise. I have also heard of, putting a person in a chair and spinning them around, making them breathe into a brown paper bag, make them breathe through a straw. Obviously, you get really, really good consent from the client first, and you want to have a medical history to make sure you're not inducing some kind of unpleasant health response. But the idea is, if you make the person feel like they're having a panic attack in front of you, they have the opportunity, with your support, to help them practice that relaxation. So once they can do it in a real situation, there is no need for them to be afraid. There is no need for them to be avoidant, because they know how to be successful in a real life situation with a real life panic attack. All right, a lot of material today. Hope you guys are still with me. If you're not, pause the video, eat a snack, and come back in a little bit. Obsessive-Compulsive Disorder, made up of two components. So Obsessive-Compulsive Disorder, just like it sounds, is made up of obsessions and compulsions. Now the difference between the two. The obsession, which traditionally we think of this as coming first, the obsession is a persistent thought, idea, impulse, or image that seems to invade a person's consciousness. So for the person who has OCD, they have a thought pop up or an image pop up in their mind. And when it says invade, it doesn't feel like it came from you. It feels like this thought is almost foreign. I don't know where this came. I would never think that. Why would I think that? I would never have that image. Where did that image come from? It seems like it comes out of nowhere. And the obsession triggers anxiety. And this is why OCD has traditionally been thought of as an anxiety disorder. Although we'll talk about that in a second. Now, what happens when this thought or this idea causes you anxiety? Well, oftentimes the compulsion is the response to the obsession. The compulsion is an act, which could be a physical act or a mental act that person then engages in to try to reduce the anxiety that's brought up from the obsession. Now, at the risk of perpetuating a stereotype here, imagine a person who is afraid of germs. Not everyone who has OCD has the germ thing, but go with me here. Imagine you're a person whose OCD is triggered by germs. You touch something that you think is dirty. Your obsession in your mind is, oh my goodness, I'm going to get sick. This is disgusting. There's something nasty here, and it creates anxiety. So then the compulsion that you feel like you have to do is wash your hands. Now, washing your hands is a good idea. So at what point is this OCD, and at what point is this just, good sanitary practice? Well, if you're washing your hands 47 times a day until your skin cracks, you've probably gone a little bit too far. All right, if I sound irreverent here, I have OCD, so I don't know. I don't guess that licensed me to be irreverent. But anyway, OCD. Diagnosis is called for when the symptoms feel excessive or unreasonable, cause great distress, take up much time, interfere with daily functioning. So maybe checking is normal for you. You check and make sure you have your keys before you leave your house, right? You check and make sure when you walk away from your car that you have the keys and that you didn't lock your keys in the car. How many times a day do you have to check and make sure you haven't lost your keys before it's causing you distress? If you can't do anything because every 2 minutes you have to check on your keys, that's taking up time. That's causing you anxiety. That's keeping you from functioning in your life. And at that point, that's when something like that could be OCD. Now, every semester I have students come to me and say, okay, well, I can't go to bed if there's dirty dishes in the sink. Does that mean I have OCD? Everyone has routines. Everyone has things that they do, and they're just your things. And it's not OCD unless it's causing you distress, unless it's taking up a lot of your time. So some examples of normal routines and the percentage of people who say they follow those routines. Buttoning your shirt from top to bottom. To me, that's weird. I do not button my shirts from top to bottom. I always start at the bottom to make sure I haven't mislined up the bottom, mislined up the buttons, but maybe that's just me. I should not exactly be held up as the case study in normality either, just so you know. Eating corn row by row, I guess I do that. Brush your teeth up and down. What other way would you brush your teeth? I don't know. Change towels daily. Yeah, I kind of have a laundry thing, so that's totally me. But these are just some examples of some normal routines. You have a routine that you like to do, you're human. Not a problem unless it's taking up a lot of time and causing a lot of dysfunction and distress. Now, the obsessive part is anxiety-based. So it's often been considered an anxiety disorder. The compulsion is an individual trying to regulate the anxiety, trying to reduce the anxiety. So if you have a person who has OCD and the obsession comes up and you prevent them from doing the compulsion, the anxiety is going to go through the roof. Now, approximately 1 to 2% of people every year suffer from OCD. Something interesting is that we see it in approximately equal amounts in men and women, which is strange because anxiety disorders typically happen more in women than they do in men, and could potentially indicate that OCD has a more maybe biological brain chemistry component rather than a like nurture, culture, parenting component to it. It's roughly equal among different racial and ethnic groups. About 40% of people who have OCD seek treatment. That's actually a pretty high number. And I think it's because of the severe nature of OCD sometimes, and also perhaps because of the public nature. If people see you doing the compulsion, then they might call you out on it. Whereas maybe some of the other things, generalized anxiety disorder, may not be as obvious. OCD might be a little easier for other people to recognize. So, as I said, these obsessions, they're thoughts that feel intrusive and foreign and does not feel like they came from you. It feels like they are outside of your control completely. So the more you try to ignore them, the more anxious you feel. So if I tell you not to think about a purple elephant, all you're thinking about is a purple elephant. And if you try not to think about the thing you're obsessing over, it's just going to keep coming back. Some other forms, other than maybe thoughts, could seem like wishes, impulses, images, ideas, doubts. So maybe you feel like this impulse to do something that you would not do, that you don't want to do, but you feel like it's kind of coming from outside of you and you have very little control over it. Now, there are common themes. These are not the only themes, but some of the most common ones, the germ, contamination, violence and aggression. Sometimes people have very violent images in their mind, and maybe even violent impulses. Maybe they feel impulses to hurt someone, but they don't want to hurt someone, and this person has no desire whatsoever to. It feels like they're coming from out of nowhere. Orderliness is another one that's relatively stereotypical. Things have to be neat. Things have to be organized just the right way. Religion and sexuality issues. So this may be a person who has very heightened morality, a person who is feeling guilty, a person who feels guilty about having a dream, for example, or something they have no control over, because they feel like that's wrong and that's guilty and I shouldn't have thought that, or I shouldn't have had that dream, because maybe pretty like severe morality there. Now the compulsions, on the other hand, are more voluntary than the obsessions. You may feel like you have no control over the obsessions, but you have at least a little bit of control over the compulsions. The problem is, why would you want to control the compulsion? The compulsion is the thing that makes you feel better. So I don't control the obsession of being afraid of the germs. Yeah, I have some control over the compulsion of washing my hands, but why would I not wash my hands if I think they're dirty? So the person might feel like they're mandatory. Now, most of the time, the person will say, you know what, this is really unreasonable. I don't need to wash my hands for 2 hours a day. That's unrealistic. They say that, and they know that, but it's still hard for them to stop, because performing the behaviors reduces anxiety. So then what's wrong with the compulsion? The problem is the anxiety comes back. It only solves the problem until you touch something else that you think is dirty, and then you have to do it all over again. And it often becomes a complex ritual. If you're feeling super anxious and a certain kind of soap makes you feel better, all of a sudden my anxiety went away while I was using the soap. Now it's not just washing my hands. I have to wash my hands with this kind of soap. I have to wash my hands in this certain way. Now, once again, this is not the only way people experience OCD. It's just hand washing is an easy example. So compulsions often take common forms that oftentimes, not always, but oftentimes are at least somewhat correlated with the obsession. So if your obsession is you're afraid you're going to lose your keys, you check to make sure you still have your keys. If your obsession is making sure that your kitchen is clean, then you have to constantly be cleaning your kitchen, right? Now, one thing it says touching, counting here. Some people who have OCD have a symmetry issue where for purposes that are really hard to explain, they might feel uncomfortable if someone touches them on one side and not on the other side. So there needs to be a balance. So if you maybe poke them in the right arm, you have to poke them in the left arm, or there's something uncomfortable there. So that's a symmetry issue, an order issue. Now, most people who have OCD have obsessions and compulsions, but you don't have to have both. Some people only have obsessions, some people only have compulsions. Typically, you have both. The compulsion usually happens after the obsession to help you recover from the obsession. So the person might feel like the compulsion gives them a level of control, but actually, because the compulsion reduces the anxiety, the compulsion is being reinforced. It feels good to wash my hands. Now I don't have to worry. And so the person starts to lose control over the compulsion as well until it feels like they have to do it. So how are we going to try to reduce this? This is going to be really, really tricky. Now, when it comes to the behavioral perspective of OCD, which receives a lot of research support, what happens is you're feeling super anxious, and at the same time you just happen to do something else and feel better at the same time. You know, anxiety will just pass if you leave it alone. Eventually it'll just pass. But what happens if right around the time your OCD, your obsession was going away on its own, you wash your hands? And then you think to yourself, wow, washing my hands made me feel better. No, it didn't. It was a random coincidence. But because you think it did, you'll start washing your hands whenever you start feeling anxious. And this is where people can develop little superstitions or develop little routines here that they feel like they lose control over the more they do it, because if it works and it reduces the anxiety and the anxiety is awful, then why wouldn't I do it again in the future? How do we treat this? Best treatment, most effective treatment is exposure and response prevention. This is a behavioral treatment that is unpleasant to the person who has OCD, but very helpful. The problem is the compulsion. The obsession will go away on its own if you leave it alone. Anxiety will go. The compulsion, though, is making the anxiety stick around longer. The compulsion gets rid of the anxiety temporarily, but it comes back. And the very act of engaging in the compulsion is really reinforcing. And so maybe it's making the anxiety come back more often. So here's what we're going to do. We're going to force the client, with their permission, always with consent, we're going to have the client do something that will trigger an obsession and then prevent them from doing the compulsion. So if we're talking about the hand washing thing, make a client touch something that's dirty and don't let them wash their hands. Now, beware, you may have to model this. Exposure can be modeled. I have heard of people having obsessions about getting sick because the silverware is dirty at a restaurant. So making them go to a restaurant and eat with the silverware, touch the silverware, can create a lot of anxiety. They'll immediately want to go wash their hands, but you stop them and you don't let them do that. Now, you maybe go first. You touch the silverware, you eat with the silverware, and you turn out just fine, to demonstrate to the client that it's not realistic to be afraid of this. Now, homework is important because, as I said earlier, the client's only with you for a few minutes, 50 minutes, maybe once a week. They have to practice this outside. So maybe having a family member or a friend that helps them engage in this can be really effective. Between 55 and 85% of clients improve considerably. This is very impressive considering the fact that OCD is often severe and often has been going on for years before people seek treatment. However, about 25% of people don't improve. So maybe then we're thinking we need a combination. Sometimes you have to combine therapy with medication. Maybe we need a different kind of treatment because the client is not willing to engage in this kind of treatment. If you're a person who has obsessions without compulsions, this treatment's not really going to be effective for you. This treatment is all about withholding compulsions. If there's no compulsion to withhold, it's not going to work. So it's not the only option, but it's one of the best options for treating OCD. Now, a cognitive perspective here would be to say every person has unwanted thoughts pop up sometimes. I had that thought, and where did that come from? I don't want that. I wouldn't do that. That's normal. Everyone has that to a certain extent. Everyone has strange thoughts pop up. The problem is that a person who has OCD latches onto those thoughts and can't let them go and feels guilty for them. And you think to yourself, if I was a good person, I wouldn't have this thought. And so then because of that, you can't let it go. So the cognitive theorist tries to help them realize that it's not about the fact that you have the obsession, it's about the way that you respond to the obsession. You continue to ruminate on it, and that's why it's a problem. The whole thing with OCD, with this cognitive perspective, is that you are trying to neutralize the obsession with the compulsion. And so they are very intricately related to each other. So think about this. You're trying to neutralize the germs with washing your hands, right? So what about some mental compulsions? Some compulsions that are not washing your hands or checking for your keys. What happens if the obsession is a violent impulse? And so the compulsion then is to think good thoughts about that person. I don't want to hurt that person. I love that person. And you go through all the things you like about that person. That is a compulsion you do to try to neutralize the effects of your obsession. Now, in reality, the obsession doesn't have any effects for anyone other than you. It's not like we have the power to think something bad about a person and cause a bad outcome. But people who have OCD often think that they do. This is the issue. If everyone has intrusive thoughts, why do only some people develop OCD? Well, they have a predisposition towards it. That predisposition could be, for instance, depressive symptoms. They tend to have more symptoms of depression. Also, high standards of conduct and morality. So we talked about that. Excessive morality that can be related to religious issues. Believing that thoughts are equal to actions. So people feel like, because I thought that bad thing about you, I've actually physically harmed you. And then we have to do a compulsion to try to undo that. Of course, thoughts are not equal to actions per se. They don't have the same effect on the other person. But someone who has OCD may not realize that. Also, people who have OCD tend to be perfectionists, and so they feel like they have to completely control every aspect of their lives. I shouldn't have that thought come up. If I was a good person, I wouldn't have that thought come up. So cognitive behavioral therapy can combine that exposure that we just talked about, that's the behavioral aspect, with a cognitive aspect here of helping people understand that having a certain level of obsession is normal. Learning to let it go and not feel like it defines who you are is very important. So you're not a bad person just because you had that thought. And you don't need to punish yourself. I mean, OCD often feels like a person is punishing themselves for having thoughts that they really don't have a whole lot of control over. So we combine the cognitive aspect with the behavioral aspect that can be very helpful, and if needed can also be combined with medication. So when we're talking about medications for OCD, the biological perspective is that there's something wrong with the brain that causes OCD to happen. One of the most common perspectives here, it has to do with serotonin. So medications that help increase serotonin are usually very helpful for OCD. So things like SSRIs, those selective serotonin reuptake inhibitors that force the body to leave serotonin in the synapse longer, can be helpful. It could also be that there's a brain structure issue, especially related to the frontal cortex, so that part of the brain that makes decisions, the part of the brain that controls thought processes. It says perhaps the caudate nuclei, which is just basically we're talking about sensory information here and the connection between sensory information and thoughts and actions. If you're a person who has excessive activity in the parts of your brain that control your thought processes, it may feel like you're physically not able to let things go. That excessive activity is keeping you from calming down and letting things go. So medication can be helpful with that. Typically, as I said, we give medications that are aimed to increase the effect of serotonin. So things like Prozac and others, Zoloft, Paxil, other SSRIs are often included. Now, these medications are helpful for a lot of people who have OCD and can be combined with therapy. The problem is that if a person stops taking the medication, they can have a relapse. That's not necessarily true of everyone. Some people are able to take the medication for a little while, get them through a rough patch, and then stop taking the medication without relapse. If you're going to stop taking medication, I always recommend that you talk to your doctor, but also weaning yourself off of it. I wouldn't say stop taking it completely. I would say take half a pill one day and a whole pill the next day. And then after you do that for a while, half a pill every day, cut your pills in half, that kind of thing, to wean yourself off of it. However, a person who is having really good benefits from this medication, who's not having side effects, who's not having a health issue that maybe indicates they should stop taking the medication, there's not really a reason for that person to stop taking the medication. Okay. Now, obsessive-compulsive disorder has traditionally been thought of as an anxiety disorder because of the anxiety triggered by the obsession. However, DSM-5 conceptualizes OCD differently because of the compulsions. They decided that the thing that really makes OCD OCD is the compulsion, which is not necessarily anxiety. It's caused by the anxiety, but maybe it has to do with an impulse control thing. So instead, they create this new little category called obsessive-compulsive related disorders, and they put disorders in that category that tend to involve impulse control problems. Now, what I will say is that oftentimes the compulsive-like behaviors, including OCD, but these also other disorders as well, is often triggered by anxiety. So if they were asking me, I'd leave them in the anxiety disorder category, but you know what? Nobody asked my opinion, so I'll just teach it like it is. So we have this different category now, including hoarding disorder. You've probably seen TV shows with people who hoard things. Trichotillomania is hair pulling disorder. Excoriation is skin picking. So oftentimes this hair pulling, skin picking thing happens during extreme stress. So it's kind of one of those things that people do to try to relieve anxiety and stress. And then body dysmorphic disorder you've probably heard of as well. I have some criteria here just for you guys to look at. Body dysmorphic disorder happens when a person picks up on some kind of flaw. Now, the flaw may not be there at all, or it may be that there is a flaw, but it's a tiny flaw. And yet, to the person who has body dysmorphic disorder, it seems huge. That's kind of an anxiety-producing thing, similar to the obsession in OCD, and the compulsion here is to engage in certain behaviors, like constantly comparing yourself to other people, looking in magazines to see if there are other people that look like you, checking your appearance in the mirror, that kind of thing. Okay, today's lecture was a ton of information, so please let me know if you have any questions about any of this. My activity for you guys here is to try to improve empathy. So with anxiety disorders being very common, it's very likely that at some point in your life you will either have an anxiety disorder or you will know someone who has an anxiety disorder. So what I want to do here is to help you understand how it would feel to have an anxiety disorder. So what I want you to do is choose one of the anxiety disorders we talked about today, and I do include OCD in this list. So you can talk about generalized anxiety, specific phobia, agoraphobia, social anxiety, panic disorder, or OCD. Choose one And then tell me how that would impact your daily life. How would your relationships be different? How would your school performance be different? How would your emotional health be different if you had these disorders? What I want you to do here is to really walk a mile in somebody else's shoes. Now, sometimes when I have this activity, I'll have students email me and say, I really do have generalized anxiety disorder. Can I talk about what really is like for me? Yes, you can. If you have suffered from one of these, you can tell me like realistically what it's like, but you don't have to do that. You can also choose a different one and just tell me, what would it be like if I had a specific phobia of needles, for example? How would that impact my life? So choose one of these disorders, tell me how that would impact your life, and that is your activity 5. Make sure that your response is at least 200 words long. And that is the end of lecture for today. Longest lecture of the semester, I am sure. But if you have any questions about any of the material, please feel free to let me know. Our next video will be a significantly shorter video that will address disorders of stress or trauma. So I will talk to you guys then.